Welcome to the deep dive. Today, we're focusing on a really critical strategic blueprint. It's aimed at tackling one of the biggest hurdles to development,
Hmm.
a healthcare workforce that just isn't meeting the need.
And the country in focus here is Morocco.
Exactly. We're not just talking about building shiny new hospitals. This is about the strategy to find, keep, and, smartly deploy the people needed to make the system work for everyone.
Yeah, it's crucial because the numbers themselves, they paint a pretty stark picture right from the start. Morocco has this chronic shortage of health professionals,
And it's unevenly spread too, right?
hugely uneven.
Hmm.
So overall, you're looking at about 18.2 health professionals for every 10,000 people. That breaks down to roughly 7.9 doctors and 10.3 paramedical staff.
Which is way below the WHO baseline.
Oh, substantially below. And then you hit that geographic issue.
That's where it really bites, isn't it?
Precisely. It's not just some abstract national average. In some places, it's a genuine medical desert.
Hmm.
You've got Casablanca maybe doing okay, relatively speaking.
Hmm.
One doctor per 859 people, roughly. But step outside the big cities,
Yeah.
and that ratio just explodes. Some rural areas. It's closer to one doctor for every 3,500 people.
Wow. So just spending more money, like the current 5.7% of GDP, isn't the whole answer if the people aren't there.
Exactly. The sources we're looking at are very clear. The bottleneck, the strategic choke point, is the staff.
Yeah.
You can build fantastic facilities, but if you can't staff them properly or if they're in the wrong place, well, you end up with expensive, underused buildings.
Right. So our mission today is to unpack the strategy to shift away from that sort of big urban hospital model towards something they're calling lean and smart.
Leveraging efficiency to tackle that workforce gap, especially in the short term.
Okay, let's unpack this then. If you need more capacity fast and you can't just, conjure up thousands of new doctors overnight,
Yeah.
what's the first lever you pull? The most effective, immediate thing?
Well, the strategy points directly to operational efficiency, specifically something called task shifting.
Task shifting. Okay.
Yeah, it's essentially a force multiplier. You take your existing paramedical staff, think nurses, community health workers, and you train them carefully to handle routine primary care tasks.
Things doctors usually do.
Things doctors often do now, yes, like certain types of triage, managing diabetes follow-ups, some basic aspects of maternal care, things that can be standardized.
That sounds efficient, definitely. But what about quality? You often hear concerns, right? If nurses take on more, is there a risk of errors or misdiagnosis? How does the plan handle that?
That's a valid concern, and the blueprint tackles it head-on. It's not just about dumping more work on nurses. It absolutely requires very clear, structured support.
Like what?
Standardized, evidence-based algorithms for every single condition or task they manage. Plus, and this is crucial, stable, mandatory, remote physician backup.
So there's always oversight.
Always. The doctor supervises the protocols. They're available for consultation, for escalation if a case gets complex. It's structured support.
And they've put a number on success for this, a specific target.
They have. The key metric, the KPI, is the percentage of primary care visits that get resolved right there, locally, without needing a referral to a specialist or a hospital further away.
And the target is?
Ambitious. Hitting 40% local resolution within just 12 months.
Oh, 40%. That sounds like it would make a real difference.
The analysis suggests it would. If you can resolve 40% of cases locally, it frees up doctors enormously to focus on the more complex 60% that genuinely need their specialized skills.
Okay, so that boosts capacity using existing staff. But we still have the geography problem. We haven't actually moved doctors into those rural deserts. How do you tackle that, getting professionals to underserved areas?
That's arguably the toughest piece, and the sources are clear. Just offering more money, well, that usually fails. It's not enough.
So what does work?
The strategy calls for comprehensive incentive bundles. It's about looking at the whole picture for the professional.
More than just salary.
Oh, yes. Significant salary top-ups are part of it, absolutely. But also things like guaranteed housing, a defined career fast track. So working rurally actually helps your progression, gives you access to specialist training maybe.
Practical things too.
Crucial practical things like schooling support for their children. You have to make the quality of life viable, not just the paycheck.
That's the pull factor. But there's a push factor in the plan too, isn't there? Mandatory rural rotations linked to residency. That sounds politically difficult.
It is highly political, and there's always the risk, right, that doctors might just leave the public system altogether, go private, go overseas, rather than do a mandatory rural stint. Brain drain.
So how does the blueprint prevent that?
Well, it tries to mitigate that risk. First, by tying the mandatory rotation directly to getting your specialist certification if you receive public funding for your education. A lot of medical training is state subsidized, so there's a service obligation linked to that investment.
Kind of quid pro quo.
Sort of. And second, that incentive package we just talked about. It has to be genuinely attractive, rich enough, comprehensive enough to make the rural service financially and professionally rewarding, or at least acceptable, to counter the urge to just leave.
So success isn't just about enforcing the rule, it's about actually seeing the numbers change on the ground.
Exactly right. The metric here is tracking physician density region by region, month by month. And the specific target is that the bottom quartile regions, those real medical deserts, must double their physician numbers within 2 years.
Double in 2 years, that's a high bar.
It is. And if they don't hit it, it means the incentive bundle isn't working. And the policy needs an immediate rethink. No waiting around.
Okay, incentives and mandates for people. Let's talk tech, digital transformation. If nurses are doing more complex work, needing remote backup, you need reliable technology. But what's realistic in rural areas where connectivity might be, patchy?
Right. You need reliability over flashy features.
Yeah.
The focus isn't on, say, building a cutting-edge 5G network everywhere immediately. That's not feasible.
So what is?
It's about creating dedicated, stable telemedicine hubs. The infrastructure goal is connecting those rural primary clinics directly to the major university hospitals. Using reliable protocols, even if they're low bandwidth, stable is key.
And the focus is on specific needs.
Yes, prioritize standard workflows for the high-volume stuff. Chronic disease management, diabetes, hypertension checks, maternal health follow-ups, things that really benefit from regular, accessible consultation.
So it's more about linking the front lines back to the specialists, not necessarily patient-facing apps everywhere.
Primarily, yes. Vertical integration of expertise. The goal is ambitious, too. Teleconsultation should eventually handle half of all referrals that currently require travel.
Half. Okay, that's a huge volume of digital interaction, decentralized data flowing back and forth. How do you manage that? How do you make sure the system doesn't just buckle under its own weight, or that you even know who is where?
And that brings us squarely to what the sources describe as the absolute administrative backbone for this entire reform. It's non-negotiable. A National Healthcare Professional Registry. An HCP registry.
Okay, tell me more. What does that actually do?
It needs to be a real-time database, tracking every single clinician, their location, their specialty, their current certifications, even their workload.
Because you can't manage what you can't see?
Precisely. That phrase comes up. You can't fix what you can't see. This registry isn't just some HR list. It's the operational command center, in a way.
So it enforces the rural mandates, tracks task shifting.
It connects all the pieces.
Yeah.
How do you know if Dr. Smith completed her mandatory rural rotation? Check the registry. How do you assess if the incentive bundles are drawing people to Region X? Check the registry data. How do you balance workload for telemedicine consults? You need that real-time view from the registry. The digital reach is one thing. Managing it requires total visibility.
Got it. Okay, so we've covered the immediate fixes, task shifting, incentives, the digital links, the registry. Let's shift gears slightly. Look longer term, say 5, 10 years out. How does Morocco make sure it's actually producing the right kind of doctors and nurses for this new lean and smart system, the supply pipeline?
Yeah, that requires a fundamental shift in the medical education system itself, both funding and structure.
Oh, so.
First, a major boost in residency slots, specifically for family medicine. The current system often favors producing specialists, who then tend to cluster in cities. That needs to pivot. The country needs more highly skilled generalists, the kind of people who can run those enhanced primary care clinics effectively.
And you mentioned the link to funding earlier, the service obligation.
Exactly. That comes back into play here. Public scholarships for medical training need to be explicitly tied or bonded to mandatory service in underserved areas, likely rural ones.
So state pays for your training, you serve where the state needs you.
That's the principle. It's a direct response to the fact that right now, the number of graduates just isn't keeping pace with population growth, let alone addressing the distribution problem. You need to guarantee not just the quality of graduates, but also that they'll actually work where the gaps are.
Okay, makes sense. What about the overall money picture? Reform isn't cheap, even efficient reform. The strategy talks about financing smarter. How? What does that involve? They mention ring-fencing funds.
Right, financing smarter. A key part of that is creating a dedicated primary and digital care fund. And then, crucially, ring fencing it.
Ring fencing, what does that mean practically?
It means legally protecting that budget, building a firewall around it, basically. So that money allocated to the fund can only be spent on specific things: the workforce incentives, strengthening primary care clinics, building that digital infrastructure. It can't be rated for other projects, no matter how tempting.
Why is that so important?
Because historically, primary care and preventative health, they're often the first things on the chopping block when budgets get tight. They lack the glamour of a big new hospital wing. Ring fencing protects these foundational investments.
And the goal of targeting funds this way is to bend the cost curve. Can you translate that jargon for us? What does that actually mean for people?
Yeah, bending the cost curve just means slowing down and eventually reversing the constant rise in overall healthcare costs. The logic is, if you invest properly in primary care, in prevention, in managing chronic diseases early and locally.
You avoid expensive hospital stays later.
Exactly. You dramatically cut down on the need for costly emergency visits, hospitalizations, complex specialist procedures down the line. So instead of resources getting sucked into what the sources sometimes call shiny projects, maybe a very high-tech isolated specialty center, you invest in the community level to keep people healthier longer and manage ongoing conditions more affordably.
That clarity on funding sounds vital. So let's pull it together. If this all works, what does winning actually look like in hard numbers?
Yeah.
Say in the next 2 to 3 years, 24 to 36 months.
The blueprint lays out 5 key measurable success markers for that time frame. We've actually touched on 3 already.
Okay, let's recap them.
First, getting that telemedicine coverage operational across most rural clinics. Second, hitting that 40% target for primary care visits resolved locally through task shifting. Third, achieving the doubling of physician density in those poorest, underserved regions.
Right, the big 3. What are the other 2?
Number 4 is about the system visibility. Having that live dashboard powered by the HCP registry showing where clinicians are and what their workload looks like. Proof that the management system is working.
And the 5th?
The 5th is absolutely critical for patient trust and the system actually functioning day to day, keeping stockout rates for essential medicines below 5%.
Ah, that's a really practical one. Because you can have the staff, the clinic, the digital link, but if the pharmacy shelf is empty when a patient gets there,
The whole system breaks down at that point of care. It loses all credibility. If someone travels, even a shorter distance now, to a clinic for their hypertension meds and they aren't there, forget it. The workforce plan and the supply chain have to work hand in glove.
absolutely. Okay, this is a complex, interconnected strategy, ambitious. What are the biggest risks? Where could this fall down?
The sources identify 2 main potential stumbling blocks. The first is behavioral or maybe political. Resistance from doctors themselves.
It's a scope creep issue.
Exactly. The fear that task shifting devalues the doctor's role or maybe compromises quality of care. It's a common pushback in these situations.
And the plan's answer is clear roles and remote supervision. Is that really enough to overcome potentially strong opposition from medical groups?
Well, the strategy is banking on the idea that the sheer relief from workload offloading, that 40% of routine cases will eventually win over many doctors. Plus, demonstrating that the protocols and the remote supervision are robust and safe is key. But it's definitely a risk.
Okay, risk number 1 is professional resistance. What's the second?
No surprises here. Funding gaps, especially when you're trying to actively shift money away from established, powerful institutions like big urban hospitals towards primary care.
And the plan mentions tapping into development finance, public-private partnerships.
Mm.
How realistic is that? Does the political will exist to make that reallocation stick?
It takes serious, high-level political commitment and transparency. That's another reason why ring-fencing that primary care fund is so important. It signals commitment to donors and partners that the money will go where it's intended, not diverted to, well, those shiny projects again. But ultimately, success hinges on leadership, consistently prioritizing primary care over perhaps more visible prestige projects.
So if they navigate those risks, if this blueprint gets implemented successfully, paint the final picture, what does healthcare look like for an average person in Morocco in, say, 5 years?
The vision is a system that feels fundamentally different. Leaner, yes, driven by data, but most importantly, far more regionally balanced. For someone living in a rural area, it means the end of maybe 4-hour journeys just for a routine checkup for a chronic condition.
So care closer to home.
Much closer. Accessible locally, provided by well-trained staff nurses, community workers who are connected digitally to specialist expertise when needed. It's about reducing that massive time and travel burden for basic, essential care.
So, the big takeaway from this analysis seems to be that success isn't about one massive hospital build. It's about treating the workforce and primary care itself as fundamental national infrastructure.
Absolutely. They're like the essential arteries for the country's health and, frankly, its economic future, too.
Which leaves us with a final thought for you to consider. This whole strategy depends massively on real time data, especially that national HCP registry tracking every clinician's location, specialty, workload. If that registry is the central tool managing this critical infrastructure, what are the really significant security and privacy challenges that come with holding such a detailed, constantly updated, high valued data set on every single medical professional in the country? Think about the power and the risks of that centralized knowledge. Something to mull over. Thank you for joining us for the deep dive.